fixed duration cohort where patients had a lead-in with ibrutinib and then had 12 cycles of ibrutinib and venetoclax combination. And again, the 5.5-year PFS was excellent. You can see 66% in the pooled population. A little bit less, of course, again, for the high-risk disease. You can see for the deletion 17p or p53, the 5.5-year PFS was 30%. And for the unmutated, again, a little bit less than the mutated. You could see at 53%. But these patients still do really, really well. And so, again, another time-limited oral combination. This is the FLAIR data. For those who don't know, this was a UK-led study, and this also looked at ibrutinib and venetoclax, but it was a randomized study of ibrutinib and venetoclax versus ibrutinib monotherapy versus chemoimmunotherapy, so a randomized study. What's also different about this study is it had sort of an MRD-guided approach to the ibrutinib and the venetoclax. So patients would get the combination, and when they became MRD negative, they then would double the time period that they were then on ibrutinib and ven. So if it took them 12 months to become MRD negative, they would double that time period. They would take 2 more years of ibrutinib and venetoclax. So just keep that in mind. So that means for some individuals, they could be on this regimen. Most, in fact, were on this regimen more than 3 years. So just keep that in mind. And so you can see here that there's no doubt that there was an improvement in the PFS for the ibrutinib and ven versus ibrutinib alone versus the chemoimmunotherapy arms. But again, keep in mind that a lot of those patients might have been on this combination, not as time limited as 12 months per se for the ven-OB CLL14 data, but obviously patients were on ibrutinib venetoclax combinations longer. And so you could see how high the PFS was at 5 years at 94%. Versus 75% for ibrutinib alone or chemotherapy at 58%. And you can see the 5-year overall survival very good as well. You can see for the ibrutinib alone, it was very comparable though, 91% versus 96%. So again, an MRD-guided approach. I actually give the people who did this study, this is quite heroic to do this, given the fact of following MRD and doing this approach. So very interesting data, but it talks, well, what's time limited and how do we use MRD and how do we extend it and when do you say enough's enough? So you just have to keep that in mind. And then, of course, we have the Amplify data that was just presented recently at ASH, leading to the NCCN guidelines adaptation of having our first oral combination in the US. Remember, in the EU, ibrutinib and venetoclax was already approved based on the GLOW data for ibrutinib and venetoclax. We hadn't had that combination or approval of the BTK and ven here until this data here. Again, FDA not approved, but sorry, NCCN has adapted this, and hopefully we'll see that we'll get approval soon. But this is acalabrutinib and ven plus or minus obinutuzumab versus chemoimmunotherapy. Remember also that this study did not include high-risk individuals because of the chemoimmunotherapy arm, so there wasn't anybody with deletion 17p or TP53 on the study. And you can see, obviously, that it met its primary endpoint with the PFS superior for AV versus chemoimmunotherapy. And you can see the PFS for AVO is a little bit better than AV as well. So AV, AVO, better PFS versus chemoimmunotherapy in this study. Now, just to hash a little bit more about the details of the study, certainly if you break this down by different groups, IGHV subgroups, you can see that the mutateds did very, very well. You can even see for the chemoimmunotherapy, which we always talked about, right? Your favorable mutated patients did better with chemoimmunotherapy. They did pretty good on this study as well. Not as well as the AVO or AV groups, but you could see in this study there was a difference in the unmutated subgroup. So the patients who did the best who were unmutated were actually AVO. And so that's something to keep in mind when we talk about, do we use a doublet or a triplet? How do we rectify that in the higher risk patient population? Obviously, I think a lot of us are looking forward to more data on that. But the unmutated, the PFS for them was 83% versus AV it was 69%. So just keep that in mind. There were also higher rates of undetectable MRD with the AVO triplet, not surprisingly. And then let's talk about a little bit of the toxicity. So what came out of, if some of you remember at ASH, of course, was there was a lot of COVID, there was some COVID-related deaths, and it was actually highest in the AVO arm. So there was 25 deaths in the AVO arm with only 10 deaths in the AV arm, and I think there was 21 in the chemoimmunotherapy arms. So there was increased toxicity. Despite that, they still had a higher PFS, but you do have to keep in mind that these combinations do have toxicities associated with them. You could see the infection complications of any grade were higher in the AV-AVO versus chemoimmunotherapy. So I think that reminds all of us that despite the fact that we have oral agents, that doesn't mean mean they don't have any toxicity, and you need to monitor your patients. And certainly there was a higher degree of neutropenia in the antibody arms, AVO, and the chemoimmunotherapy, not surprisingly. Very little with the way of tumor lysis. So you see a little bit of AFib and hypertension and a little bit more, and obviously the BTK arms. But not unexpected with some of these toxicities with the adverse events of special interest that we see with either A or V. There also is Matt Davids and the Dana-Farber group had a phase 2 study looking at, in the treatment-naive patient population, looking at higher-risk patients getting AVO. Now, this was a sequential approach. They started with acalabrutinib and then added obinutuzumab, starting obinutuzumab and ven, I think, starting cycle 2, and then from 2 to 7, and then they were on AV. So then they continued on AV. And if they became undetectable MRD, they can stop therapy. If they still had persistent disease and MRD, they can continue AV. So just keep that in mind. So patients, several of those patients obviously got treated more than a year for sure. You could see at cycle 16, 42% of the patients with high-risk disease, TP53 mutations, were able to achieve undetectable MRD at cycle 16. So really high levels of MRD undetectability, and you could see the 4-year PFS in this high-risk group was 70%, and overall survival 88%. So very nice, and we're going to obviously be very keen to looking at longer-term follow-up of the triplets in our high-risk patient population. This is fairly well tolerated. You can see that, again, things that we would expect of the combinations, similar to what I showed you before with the Amplify data. Infection of any grade was about 46%. I showed you it was about 50% in the Amplify data. There was some hypertension, of course, infusion-related reactions because of the obinutuzumab. You can see bleeding risk. But in terms of the grade 3 or more, mostly it was infection, hypertension, a little bit of atrial fib and TLS, but under 5%. Now, what about data with zanubrutinib? Obviously, we have data now with zanubrutinib in both doublet and triplet combinations. Here's the bovin data. Also, this was an early phase 2 study looking at it in a high-risk patient population of about 13% had deletion 17p or p53. The majority were unmutated, and you could see very high levels of response, 96% of undetectable MRD in both peripheral blood and the bone marrow. So a very active combination in high-risk patients. Here's the toxicities with the bovin regimen. Again, mostly grade 1, grade 2. Again, you could see some grade 3, really some cytopenias, some diarrhea, infusion-related reactions as expected. So things that we would expect with the agents that we know. So it'll be really nice to, this study is closed, it'll be really nice to see when we talk about doublets and we talk about, well, which is better, that question that Nitin raised to us earlier about in the younger patient, do you do oral versus, ven antibody combination? This is a randomized study that hopefully we'll see some data too, looking at AV versus venetoclax and obinutuzumab. Now this study's a little different because it has some MRD with this, a little MRD guidance with this study as well. So patients will be evaluated at 12 to 14 months, depending on when they started, which arm they were on. They will be evaluated for MRD. If they're still positive, they can continue the AV for another 12 months. If they're in the VO arm, they'll continue the V for another 12 months, and then all will stop. So a little bit MRD guided data, and also a little bit of looking at which oral doublet might be better in the treatment naive setting, either the oral or ven-G. So that'll be a very interesting study, and hopefully we'll see results soon. And then, of course, as I said, there's other BCL2 inhibitors that are being evaluated. Sonrotoclax is one of those. There's others, lisafticlax, and so on and so forth. This is data from zanubrutinib and sonrotoclax in the treatment-naive setting. And this is a randomized study looking at zanubrutinib and sonrotoclax versus venetoclax and obinutuzumab. So another randomized study to show, hey, oral versus ven-G, what does this look like? And so this, I think, will also be a great study. This is also closed to accrual, and hopefully we'll see data very soon about this. And then the phase 3 CLL16 trial will look at ven obinutuzumab versus AVO in high-risk patients with CLL. So deletion 17p or p53 or complex karyotype. They could be fit or unfit, and as long as they're untreated, and so they'll get ven-G or AVO. And if they have MRD on the AVO arm, they still can continue with acalabrutinib maintenance. So again, another study that will sort of look at ven-G versus either doublets or triplets, another combination, so we can see, what might be the best front runner in the treatment-naive setting. But in particular, this is for patients with high-risk disease. Just a comment about, now that the oral combinations are added to the NCCN guidelines with acalabrutinib and venetoclax, usually this is a little different than how we give this versus Ven-G. So usually we front load with the BTK inhibitor. Some studies did 2 cycles, some studies did 3 cycles. That tends to debulk patients, shrinks their lymphadenopathy or organomegaly, and makes it much easier then to do the venetoclax ramp up. So that's usually what you'll see in the clinical trial arena, and certainly most of those patients then when they start their venetoclax are a lower risk for tumor lysis. Makes it much easier to do this as an outpatient strategy. Okay. So let's just go back quickly to the question that we had done earlier for the adult patient who was treatment naive, who is younger with a good performance status, no significant comorbidities, but he was unmutated. Assuming the patient has expressed interest in pursuing a time-limited therapy, with current guidelines in mind, what would you recommend as treatment? Venetoclax obinutuzumab, ibrutinib venetoclax, acalabrutinib venetoclax, obinutuzumab, or zanubrutinib venetoclax and obinutuzumab. If you can scan to answer, that would be great. I guess we're not going to see the answers, huh? All right, fair enough. All right, so let's...
There's answers now.
Oh, did they show? Oh, I just can't see them. Oh, there they are. Okay, yeah, but how can I see? Okay, so it looks like, and again, not a right answer, so it looks like a lot of people said time limit Ven-O, some people said IV, some people said AV, so it's all across the board. Yeah. Okay, excellent. And there is no right answer, so I think that's pretty appropriate. Okay. All right, so let's talk about continuous therapy, right? Because that's still an option for our patients. Okay, so I think just to remind everybody that we try to recommend, and hopefully this increases in practice, we try to recommend that patients get tested. Obviously, FISH is, I think, pretty well known, and I think we really do have many folks testing, doing the cytogenetics on patients. I think what they forget is it doesn't capture the TP53, which really you need to sequence the whole TP53 gene to look at TP53 mutations. And so we recommend doing that. And it's important because obviously it talks about, helps us define what therapies might be better for those individuals. But remember, it's relatively uncommon in the front line. TP53, 17p deletions are, somewhere between 6 to 8% in the front line, but obviously increase in frequency with subsequent lines of therapy. So it's important to retest your patients prior to subsequent lines of therapy to understand sort of a little bit about, their whether or not they've acquired additional mutations or resistance and concern when we think about subsequent lines of therapies and what to use for them. So that's important. Your IGHV, if you've tested for that once, you don't need to repeat it because it stays the same. And complex karyotype is something also that can evolve over time. And so certainly we also recommend repeating that as well between subsequent lines of therapy prior to new therapy, because you can acquire different cytogenetic abnormalities. So it's important to know what you're dealing with prior to starting subsequent lines of therapy. All the therapies, again, are listed, so I'm not going to burden you with that. Just to go over on the newer generations, the second generation BTK inhibitors, this is pooled analysis from several studies with acalabrutinib in high-risk patients with CLL. And you can see here that, again, I'm not showing compared to chemoimmunotherapy where the rates of PFS and survival were dismal. Now, with these, with the BTK inhibitors, the survival of our high-risk individuals are remarkably well, and you can see how well this is done with acalabrutinib with the PFS in long-term from these pooled studies. What was mentioned earlier was the one difference there was obviously the Elevate-TN study, looking at the addition of obinutuzumab plus acalabrutinib versus acalabrutinib. In high-risk individuals, the addition of obinutuzumab doesn't add a benefit to the PFS versus acalabrutinib alone. So I think many of us would just give monotherapy versus the antibody combination in our high-risk patient population. With the zanubrutinib data, we now have obviously emerging data with zanubrutinib, looking at if the Sequoia, remember, had several arms, for those of you who are familiar with the study, and arm C was deletion 17p, getting zanubrutinib as monotherapy. And then arm D, they had a cohort with deletion 17p or p53 that got the combination of zanubrutinib and venetoclax. So I'm going to go over some of the results of both of these data, and you can see again the PFS looks very, very good, even with just continuous zanubrutinib here at 72%, 60-month PFS, and so that's excellent for our patients with high-risk disease. Now the combination looks even better. So now, mind you, this is continuous therapy. So they got zanubrutinib and venetoclax, but were followed by continuous zanubrutinib therapy. So the PFS is higher in the combination and looks very good. And so this was part of that earlier question that, again, Nitin had raised earlier. Is this a strategy? Can you do, Zanu, Ven, and continue a BTK inhibitor in our high-risk individuals to achieve these, possibly deeper remissions and better PFS over time? And I think longer-term follow-up will tell us, I think, whether or not, that would be a great strategy to do, or whether or not we can do something that's time-limited for these individuals with some of these combinations. And then for many of you who don't know, the Alpine data, which is a relapse refractory, wasn't a treatment naive study, looked at zanubrutinib. That was the pivotal study looking at zanubrutinib versus ibrutinib. There was a cohort of patients that had deletion 17p or p53, and there was a little bit of a difference in the PFS between zanubrutinib and ibrutinib, but again, just kind of echoing that the patients, with 17p high-risk disease are doing much better with the BTK inhibitors, and there was a little bit of difference in response in the PFS here in this study with Alpine with zanubrutinib versus ibrutinib at 59% versus 41% at the 36-month mark. So just another data point. And then just to remember that when we talk about continuous therapy, whether it be covalent BTK inhibitors or non-covalent BTK inhibitors, the adverse events of special interest still applies to all of these agents, but just with different frequencies, given some of the head-to-head data that I alluded to, such as Alpine and Elevate RR with acalabrutinib versus ibrutinib. Cardiac side effects with the newer agents, but it's still important that we keep that in mind because they still occur with all of this class, and so we monitor for AFib and hypertension. You can have some cytopenias with these agents, that we know that they have an increased risk of bleeding and bruising, so we try to remind our patients if they're having procedures to let us know and teach them about that, and whether or not if our patients are on other anticoagulation agents, and whether or not if depending upon that, whether or not we're comfortable to recommend a BTK inhibitor if they're on dual agents or not. So we have to think about all those issues. And then, of course, infection, I've showed you with some of the data and from some of the clinical trials that we always tell our patients, that they need to monitor for infection and call us because they're not, their CLL puts them at risk, but certainly these therapies put them at additional risk as well. And with that, let's go to our older patient that we talked about earlier. So this is our older patient with symptomatic high-risk CLL and a poor performance status. She has some comorbidities. Assuming all the options are available to her, would you now consider, in order to maximize efficacy in our high-risk setting, time-limited venetoclax obinutuzumab, any time-limited BTK ven regimen, continuous therapy with acalabrutinib, continuous therapy with zanubrutinib, therapy with zanubrutinib venetoclax followed by continuous zanubrutinib? If you can scan to answer, it'd be greatly appreciated. Now I can see it down here. Okay, so we still had some people with time limited, but the majority were continuous therapy with a BTK, either acala or Zanu. And a large number of a large number of you said zanubrutinib ven followed by zanubrutinib. Okay, excellent. Okay, so I'm going to hand this back to Nitin.
All right.
Thank you.
All right, so we'll now go to the second part of the talk. So we'll now talk about relapse refractory CLL, maybe for the next 20 minutes or so, and then we'll have some time for Q&A. And feel free to, through your, phone or app, you can submit questions to us, or later you can ask on the podium. All right, so we'll again start with a couple of cases, and again, we'll have some discussions about these cases in the group. So again, now we're talking about relapse refractory CLL. So you have a 68-year-old gentleman in your practice who has, you can see the genomics in the center of the slide here. At baseline, at the time of diagnosis or before first treatment, patient had unmutated V gene. had deletion 13q, no deletion 17p, TP53 is not mutated. So basically, patient has unmutated V gene. You can see the treatment history on the right side. Patient gets a covalent, first-line covalent BTK plus Ven combination. So you can think of ibrutinib or calazanu or whatever. They got a doublet for 1-year treatment. And now, after finishing treatment for about 2.5 years after end of treatment, patient is now progressing. One thing Dr. Lamanna talked about in her case discussion is that, IWCLL and the NCCN guidelines, and as a practice, especially for patients who do not have known 17p deletion, I think it's important to retest to both for 17p deletion as well as p3 mutation, because you could acquire these abnormalities with time. So this patient, those were tested and they were not present. Also, I think there's an argument to be made, and there is data that though it's a time-limited approach, but certainly with continuous BTK, we see mutations in BTK, PLC2, and there is also data with venetoclax with the BCL2 G101V kind of a hotspot mutation. Those were tested as part of a panel. I would say these are not very routinely tested, but maybe this patient was in an academic center. These were tested, and they were not present. So with that kind of a background, so first there's a second-line case to say, first-line time-limited approach. We'll start with John this time. I guess, what do you kind of think about this patient in terms of starting? Patient got BTK Ven, maybe let's assume Acala Ven or ibrutinib Ven, and how do you think about retreatment or other options for this patient?
Yeah, so the patient's still relatively young and fit for the most part. The median PFS for an unmutated IGHV in like Captivate and some of these, is going to be around 4 or 5 years, somewhere around there. So, 2.5 years after the end of treatment isn't unheard of to see them starting to progress and maybe need treatment again. It's a decent time off treatment. I think we would like to have it better. But I don't think it necessarily rules out a retreatment with the same approach and trying to get another fixed duration. Some questions I'd like to know and we don't have. Was MRD checked? Did they get MRD negative the first time? If they didn't, maybe there's a role for incorporating an antibody here potentially to help that second remission get a little deeper and more meaningful. I don't think this patient has failed any of these agents yet. And I think, it's absolutely reasonable to offer another time-limited approach. And again, limited data to really tell you which time-limited approach. But sometimes if a shorter remission like this, even if they got, let's say, MRD negative because of some of the higher risk features, I might consider incorporating an antibody like a triplet-based approach for this type of patient. I don't know if they need Pirto yet, honestly. They haven't really had an intolerance, and they haven't really failed the covalent. And we do know that this drug can, salvage some of these patients for us in a tight spot. So I'm not quite ready to go there for them. CAR T is there. They've been exposed, but again, not failed these drugs. We're really thinking about that approach for true double refractory type of patients who are losing options of durability. Durable options, and so I think CAR T not quite yet for this patient.
So I think on that note, I think the point you mentioned, John, I think it's important to emphasize, and we heard about this in the CLL main session a few hours ago, double exposed versus double refractory. So this patient, certainly I think is still sensitive to covalent BTK inhibitor, still sensitive to venetoclax, has never had yet obinutuzumab. So I think, as you said, I think most of us will likely reuse those options before moving to Pirto or CAR T for that matter. But technically, patient is eligible for the, I guess, the label for both Pirto and CAR T. Dr. Lamanna, your thoughts about this case?
Yeah, no, I agree with both of you. I think that's true. I don't think we would consider this person could be rechallenged on those therapies. They don't seem to be refractory. So I think those are options. Whether or not Pirto is an option, of course, but that also then is continuous therapy versus retreatment, which could be a time-limited therapy, and the patient's still young. So I guess that you would have to have that conversation of whether they really wanted some sort of continuous approach versus retreatment to get off of therapy. And we could even add, we not only oral would be retreatment, we even talked, we could, if you said antibody, they could also be offered ven obinutuzumab, as well.
So I wonder just on this time off therapy, right? So this patient progressed 2.5 years later. Presumably, if you do another time-limited approach, now you add obin, certainly you can add to the depth of remission, but let's assume you were to do a BTK ven again approach. I guess maybe the expectation will be that probably the next PFS or time off therapy may not be 2.5 years, probably likely less. So given the patient relatively young, they will likely fail again. I guess would that sway you in this patient to maybe consider a continuous BTK kind of long-term therapy, or you will still attempt a time-limited approach for this patient?
Yeah, no, I think it's an important question, and that is one of these issues, particularly when we have remissions that might be even longer, and now the patient is, let's say, 73 or 74, 75, and they got treated initially at 68. I think that comes into play. I think the patient's age is still relatively young. Maybe he wants a fixed duration. I'd be still willing to go there because I don't think even after that remission, he will technically have failed any of these drugs. And a lot of the data that we'll see is that more likely than not, even when you start a continuous treatment, then he'll probably respond pretty robustly and durably.
But I would certainly think about a continuous approach if he acquired a 17P.
Sure, okay. Or maybe if the time of therapy, well, let's say was 1 year or 1.5 years, probably.
If the time was shorter, I think that would be problematic.
Yeah. Got it. All right. So, and then we have a second case. So this is a more refractory patient. She's 77. You can see the genomics in the middle. So she's unmutated V gene, 17p deletion, does not have p53 mutation. The treatment history is listed on the side here. So first line acalabrutinib, continuous acala, 4-year remission, progressed while taking acala. In the second line, you follow the Morano regimen, Ven-R, though per NCCN, you can also use Ven-Obin, and many of us may probably use that, but nonetheless, patient got Ven-R. And after 2 years of Ven-R, patient had a 2-year remission, and then patient progressed. And the third line, appropriately, Pirto was started, and patient now has about after 1.5-year remission while on Pirto, patient is progressing. Patient, you repeat the testing, patient already had 17p, you, I guess, reconfirm 17p deletion, the rest of the genomics kind of remain the same. So the patient is now looking for a 4th-line therapy. She is, I guess, 77, maybe now at this time, acala, Ven-R, and pirtobrutinib. I guess, so here, I guess, what strategies would you consider? I guess the first bullet point is assuming retreatment is not an option, and I think that's probably referring to retreatment with venetoclax. But maybe I will ask you guys a question if you wouldn't think about retreatment here, or you really will be thinking of, I guess, the bullet point 2 and 3 listed here. So Nicole, maybe we'll start with you first here.
Yeah, I mean, this person also is, it says their performance status is 2 with limited mobility, so that's not good either.
Yeah.
I think I would be certainly looking for a clinical trial. I think the BTK degraders would certainly be an option. There are other clinical trials that I think would be an option for this person. Whether or not CAR T is an option, I'm not sure if this person's got limited mobility with the comorbidities. But you always have to think about that, because now, I mean, fantastically, this woman had 4, 6, 7.5 years and she's got a 17p. So it's amazing. She's done so well. But certainly we know that subsequent lines of therapy are probably going to be short-lived, and so normally we would think CAR T or some bridge to more definitive therapy, knowing that the response, her PFS, was probably going to be short. But I would consider a clinical trial for her.
John, your thoughts about this patient?
Yeah, I think, these triple exposed, triple refractory are the trial patients that we need to know the best approach for. I think this patient, you can still be somewhat creative here on what you can do. Ven has not really been refractory there. I definitely am going to probably add Ven back on. It doesn't seem like there's a BTK mutation. Maybe there's some synergy that you can reestablish with the 2 agents. And try to eke that out, and whether or not you add in the antibody or not, even though the data would suggest the antibody is not helping the del-17p patients, but in the triplet approach, maybe it seems to actually have some effect. But
I'd be nervous giving this lady a triplet, though.
Yeah.
But I agree, you can get creative.
Yeah.
No, I think on the similar line, I was thinking if, let's suppose clinical trial is not an option, then I was thinking similar to John, what you were saying. Maybe you can go back on Ven. Do obin maybe if she can tolerate it, and maybe don't stop Ven at 2-year mark. You can just continue long-term Ven, just because are running out of standard of care approved options for the
Yeah.
patient. So I think that would
No.
be a practical strategy, I think, to consider for older patient as well.
You can definitely get creative.
Yes. All right, with that, we'll move to John for the talk on relapsed refractory CLL.
Okay. All right, thank you for that. So I'll take us through the relapse refractory setting. And speaking of getting creative in this setting, here you can see some of the options that are going to be available to us, and we'll talk about even more of them in the next line, that double refractory patient. This is in the second line or subsequent treatment. You can see it pretty much looks the same with a couple additions here with pirtobrutinib being there, even though it's not kind of in the label if you've only had a covalent BTK inhibitor. It is in the NCCN guidelines if there is resistance or intolerance. You can use the drug earlier potentially, and we use it frequently in our clinic. The other thing of note here is that obinutuzumab is actually the preferred regimen. The data that has been rituximab was approved in that relapse refractory, and that was based on the Murano data, which used rituximab. But now the guidelines, we have multiple studies showing obinutuzumab being the superior agent against rituximab-based treatments. And so this is extrapolation, but nonetheless, this is how I practice. I think many of us practice for many years, and now it's kind of being reflected to try to kind of roll it out there, this understanding that the obinutuzumab has a lot of power to it and is the preferred antibody, essentially, in any line of therapy that you're using with our patients. It doesn't change much if you're del-17p. It's all the same kind of approaches as you can see. When you are now double exposed, double refractory, triple refractory, et cetera, I guess in the double exposed, double refractory patients, we have CAR T and pirtobrutinib, both FDA approved on indication in this setting. And this is what I was speaking about getting creative. We have known that IMiDs and lenalidomide have activity in CLL. We still have PI3 kinase inhibitors, which there has been good data. We forget about it, but PI3 kinase inhibitors with venetoclax have shown really good synergies and actually higher MRD rates. And so, there are some things here, particularly for our double and triple refractory patients that may be to reestablish some response. The phase 3 Bruin study is what kind of pirtobrutinib is getting its approvals on. This was building off of the Bruin 1-2 study, which was the phase 1-2 that showed us a median PFS in that large phase 1-2 study of about 19 months. In the phase 3 trial here, this was pirtobrutinib against idelalisib rituximab or BR. Important to note, 80+% of patients got IDEL-R, so it was really looking at a pirto versus IR kind of study. And here we see median 3 prior lines of therapy, mind you, so patients are coming in 4 lines essentially. Half had also venetoclax and were double exposed, and many of those were probably double refractory. And we see the median PFS of 14 months in the pirtobrutinib arm, 8.7 months in the idelalisib arm, and IDEL-BR arm, and that was a strong, statistically significant difference. Now, one thing to point out, though, is that you can see the pirtobrutinib curve. Almost everybody has fallen off of it by 2 years. And so in this very heavily pretreated population, we need other agents. It's not something that we can necessarily rest on our laurels saying, hey, this drug is going to salvage us long term. How does this look in patients who've never had chemotherapy, who haven't had 2 prior lines of chemotherapy before they failed their ibrutinib and their venetoclax? Probably looks better, but nonetheless, when you're getting into this scenario, we still need options, particularly if you're in your younger patient, still in your 60s in this scenario. What you can see here is when you look at the subgroups, essentially the pirtobrutinib shows improvement in all high-risk subgroups, particularly the high-risk subgroups, del-17p presence, clearly favoring pirtobrutinib. Those with del-17p and p53 disrupt or mutation, favoring pirtobrutinib. The unmutated patients being present, that is favoring pirtobrutinib, the complex karyotype. So no matter how you kind of slice and dice this data, pirtobrutinib is essentially more effective than our IDEL-BR arm, which is nice to see and leading to the efficacy and the approvals of this agent. So pirto's in a large development phase right now, and In the relapse refractory setting, some other big studies are going on. There's some good data with venetoclax pairing and even anti-CD20. So there's been some frontline data with PVR, PVO, some relapse refractory data with PVR. There's a phase 3 trial of PVR versus VR ongoing currently, the 322 study. And then obviously we're moving the drug up potentially, and because it is so selective, it is such a well-tolerated agent, it has potential to disrupt this frontline space, and is going against ibrutinib in that treatment-naive CLL patient population. CAR T is out there. It's in CLL as small molecule doctors, basically. We always seem to have more small molecules to give our patients, and I don't do CAR T myself. I'm a lymphoma physician, and we have these agents, and so we've relegated CAR T further and further lines down, particularly with pirtobrutinib and potentially with some of the other agents that we're going to show you. But nonetheless, it's out there. But in CLL, it's not quite the kind of home run that I think we all hoped for. While it can potentially be curative, I think we do believe that, it's potentially only curative for maybe 20% of the patients. As you can see, it's those CRs that aren't progressing. And if you don't get into a CR, you are going to fail, and if you don't respond, clearly fail very early. But you can see if you do have a partial response, there is some benefit, some clinical benefit, as that median PFS is pushing out to a little over 2 years. And that might look a little bit better than Pirto at the cost of all the toxicity. So think of our CLL patient populations, they're in their mid to late 70s. If you're talking about an easy pill versus a potentially toxic CAR T cell therapy, many of them in these conversations, I think we can all talk to you about our experiences, they're saying, well, let's try the pill first and see how that goes. That's kind of how they're thinking about this process. We are looking to see how can we enhance and augment that response. And there was some data that was presented last ASH by Dr. Weirda, looking at ibrutinib introduction, because there was a lot of preclinical data showing that CAR T cell function and outcomes were better in patients that were apheresed on ibrutinib, and that those outcomes were in fact looking a little bit better. So this new cohort in the Transcend 004 study was there and put into place. And this was basically in patients, the ibrutinib isn't there necessarily to treat the CLL. Most of these patients, and I think all of them actually had prior BTK, most of them had progressed and were resistant. It was really there in order to modify the T cell component. And so they started the patient during kind of prior to pheresis, and then continued that on for upwards of 90 days, and some patients were even longer post-pheresis, or post-infusion, I'm sorry. And so what we saw was that response rate did in fact increase about another 20% or so. The CR rate nearly doubled from about 20% to 45%. And the PFS started to look a little bit better. And so high rates of MRD4. So I think this has informed, I think, a lot of what we're doing when we are thinking about our CAR T patient. We are essentially putting them back on BTK inhibitors. The one big caveat is it restricted to ibrutinib? Is this BTK agnostic? And we don't really know that. And I think if you're really trying to follow this data and you've got a relatively younger fit patient, getting them back on ibrutinib is probably a reasonable thing to do, because that is where the data is at. And we're in a little bit of a data-free zone if you're using other BTK inhibitors. Not that I think it's not going to extend to them, but we just don't really know. So we talked about retreatment a lot, and I think this is a new relapse patient. We usually think of relapse patients as people who are kind of refractory or resistant to some treatment, but with our fixed duration approaches creeping into CLL, these patients really aren't relapsed and refractory, or they're not refractory or resistant, but we didn't really know how do they respond after it. And frankly, we still don't have lots of data out there. But nonetheless, the Captivate study, which was ibrutinib venetoclax for fixed duration or an MRD-driven cohort, tried to address this question and followed these patients rather long-term for up to 6+7 years, some of them. and was looking and following and actually on protocol mandated how you retreated these patients and when you could retreat them and with what. And so because of that, many of our patients, of the 61 progressors on the study, 36 initiated retreatment per the protocol. Most were retreated with just single agent ibrutinib, and I think that's fine and awesome, and we want to know what that response is. I think really the question we really want to know is, what does I plus V look like again? Unfortunately, we only had about 11 patients there on study get retreated with I plus V. Nonetheless, the overall response rate was very high, and this early data with the ibrutinib retreatment, I have several patients that just restarted on ibrutinib, really gave me confidence that, hey, fixed duration, we can do this. We're not harming the patient. In fact, we can, reestablish responses once we initiate treatment. The overall response rate looks good in the I plus V, but in I plus V it was a 50+% CR rate. In these 11 patients, take it with a grain of salt, it looks a little bit less. Again, these patients on treatment or getting retreatment with I plus V were probably some of the earlier relapses and maybe the higher risk patients anyway. And I think that's something that we still don't quite understand. We don't have a huge patient population being retreated. AVO from Dr. David's study also has reported, these 5 or so cases showing that, in fact, you can regain response. Many of them can get MRD negative again, and those responses can be durable as well. But again, we're talking single digits on a single hand number of patients here from this specific study, and the whole body of the literature, we're still like under maybe 100 patients that have kind of been reported with well-validated, documented outcomes. We have Ven-R also at the final analysis, the 7-year final analysis did allow some retreatment, and they amended the study and added new cohorts to allow retreatment on those patients who stopped after the 2 years, who then progressed. They allowed them to get retreated with Ven-R again for another 2 years. What we see, again, patients can respond, but what you look at is the median PFS is about 2 years. So that's telling you half the patients actually were progressing on that retreatment. And again, this is kind of self-selecting some of the worst patients, those who are relapsing the soonest, who are then being able to be retreated during the study while it was ongoing. But nonetheless, it's I think a little less encouraging or less exciting than I would have wanted to see. The median PFS with Ven-R the first time around was, I think, 50 months, somewhere around there. And so here we see on the retreatment is a median PFS of 2 years. Half the patients progressed on drug. But nonetheless, they respond. It's just, it's not as durable seemingly. Some data from over the summer also was starting to ask this question. This is a phase 2 study, the HOVON REVEAL study, looking at exploration of retreatment with venetoclax-based treatments. Remissions are possible. Again, 15 evaluable patients were reported, and the response rates are very, very high in these patients who had had prior Ven-G or Ven-R. And when they got retreated, they got basically venetoclax acalabrutinib for 2 years. And those patients who are evaluable at cycle 26 are basically at the end of that treatment. The MRD rates in the bone marrow weren't crazy high, but it was again Ven-Acala, but the response rates were very, very high, and again showing that they're not Ven resistant, and in fact we can get these responses. So I think we need to see more data. This is only 15 patients, and it just shows you the dearth of information that we actually have on understanding this. But I do feel confident about restarting continuous therapy BTK inhibitors, and I think we're not really doing any harm to our patients by showing them the best drugs as their initial treatments. So here is a polling question. I want to reconsider our 68-year-old with relapse refractory unmutated IGHV, confirmed progression 2.5 years after the end of treatment with a first-line time-limited BTK venetoclax regimen. In your opinion, is there any role for a retreatment strategy in this setting? Why or why not? You're unsure, you're unfamiliar with the evidence, no, lack of evidence for retreatment, no, the strongest evidence supports non-covalent BTK inhibitors in this setting, or 4, potentially non-covalence is a standard of care, but evidence for retreatment is encouraging, and yes, I've seen enough evidence to be convinced you can retreat. All right, so I must have done somewhat of an okay job with convincing you we can retreat here. So I think so, and we need more, definitely, but I think we can do it. All right, so very good. So how do we address this resistance? Like I said, CAR T, if we didn't keep developing molecules to keep using, maybe CAR T is going to be creeping in sooner and sooner, and our experience might be growing larger and larger with it. But we keep trying to address our resistant mechanisms, and that's the one nice thing about CLL, is that we really have understood the resistant mechanisms and are really attacking those specific resistant mechanisms. And one way to do that is with BTK degraders. And so there's two that are out there that have gotten a lot of clinical evidence. There are others in development. As you can see here, the AbbVie molecule on the right. We haven't seen much clinical data from those, but the two on the left side, the BGB molecule, the B1 medicine, and the Nurix molecule are kind of leading the way in terms of that clinical data. And basically, they hook into BTK, bring it into the U3 ubiquitin ligase complex, ubiquitinate the protein, and it gets degraded, and then you eliminate the protein, and you can now knock out B-cell receptor signaling via degradation of BTK. And so bexobrutideg is the Nurix molecule. It's now been named. It's active in our patients with heavily pretreated CLL. Over the summer, both of these molecules showed updated data and longer-term follow-up. This is from the phase 1 and first-in-human studies. And again, heavily pretreated patients. They're coming in basically fifth line. Many of them had double and triple exposures, and many of them had BTK mutations, frankly, and other high-risk mutations. And what you can see here is this response rate is very good, overall response rate of 80% in these 47 evaluable patients. You can see the high-risk features that it's kind of agnostic of what feature you have. You're responding to this drug, and actually very durably. We don't see the swimmer's plot here, but it looks really good. And here is the BGB 16673 compound. This is 66 patients treated. Overall response rate, again, 80%. We see more of like a BTK response here. We don't see crazy depth of remission necessarily, but again, heavily pretreated patients, relatively low CR rates, median PFS not necessarily reached, and at that kind of phase 2 kind of progressing dose, really high overall response rates. And then on the right side, irrespective of double exposure, triple exposure, and other high-risk features, you're seeing overall response rates of anywhere from 70 to 90%. So really exciting. Again, durable. We have patients now, the median follow-up on these studies is now pushing out over a year, and some of these patients are on these drugs for now approaching over a year. So it's exciting. It's actually a pretty well-tolerated agent as well. We do see some BTK and side effects of these drugs. BTK class effects, bruising, infections, things like that. But nonetheless, overall, very, very safe and pretty well-tolerated agent. The other thing not to be sleeping on, I guess, so to speak, is bispecifics in CLL. And epcoritamab has shown the most data, basically, that we have in the CLL space. And when we first saw the first kind of 20 or so patients, we actually saw very high CRS rates, grade 3 CRS rates, about 15 to 20% grade 3 or greater, which was some of the highest in lymphoma. And that's due to circulating disease, a lot of the medullary disease that's going on in the spleen and the bone marrow, and a lot of CRS occurs because of that. And so in this study, they did an optimization, sort of like how we use it in follicular lymphoma, with 3 step-up doses before you're at your full dose, and that did start to help mitigate the CRS, and probably how we will start to use this. But I think we still need to get it a little bit safer and maybe debulk patients a little bit deeper before we bring the drug in and find out ways to do that. But nonetheless, and again, I think 5 prior lines of therapy was in this study, overall response rate of 60%, and interestingly, the CR rate was around 30+%, which was rivaling what we saw with CAR T-cell, which was a little bit easier to use as an off-the-shelf agent. And now, as we have an optimized step-up regimen, looks like this can go forward, and an exciting approach to use for our patients. So which statement now matches your thinking on the efficacy of BTK degraders, post-covalent and non-covalent, as well as venetoclax in relapse refractory CLL? You're unsure, you're not familiar with that evidence. Active in relapse refractory CLL, but not when resistant mutations are present. Active in relapse refractory CLL, except in cases of those triple exposed. And active in relapse refractory CLL, regardless of resistance to mutations or triple exposed status. Yeah, I think we saw the phase 1/2 data that's showing, and a very active agent, 80% overall response rates.
Perfect. All right, so we'll have a few minutes. So just kind of a overall takeaway from the symposium, I think we heard that the frontline therapy of CLL, is really evolving. We saw some excellent data with the obviously BTK inhibitor monotherapy, BTK BCL2 combination, and now some of the data with the triplets, mostly with the Acala triplets, but also some emerging data with Zanu, and also some emerging data we are looking forward to with Zanu's and venetoclax. And I think for the first time, at least in the US, we will have an all-oral doublet oral therapy, as well as a triplet therapy, which will, to kind of along with venetoclax, which up until now was the only time-limited approach. We also saw data about what to do for patients who are double exposed or double refractory, namely pirtobrutinib and CAR T-cell therapy. And I really, as John kind of alluded to, I think the BTK degraders are a fantastic class of molecules. I think they just came about in the last few years, and are really, I think, changing the field and moving quite aggressively in the field, which is wonderful. And I think we look forward to, hear more updates about those trials, more combination therapies, early lines of data. And also, I think CD20 bispecific kind of has somewhat lagged behind, but hopefully will catch up in the field of CLL as well. So with this, we'll have maybe maybe 1 or 2 questions we can take. We have, I think, a couple of minutes here. If anyone has any question you want to ask on the podium, please go ahead. And then I may take 1 question from the session. Go ahead, Jeffrey.
Yeah, Nathan, I want to go back to the case, that triple exposed patient.
Okay.
And say something provocative. That patient had a 17p after Pirto, right?
Yes.
So we don't know the BTK mutational status for that patient. Post Pirto, the likelihood of a 481 is low, so probably it has a 474 or a 528. Assuming they have a BTK mutation.
Sure.
Would it be crazy to, depending on the mutation, go back to the covalent BTK, Acala or Zanu, and then throw in the bispecific? Because it could actually take care of the CRS issue when you combine this. I mean, again, John presented the data. The other advantage of the CAR T with the ibrutinib is actually the CRS is much lower. And you improve the T cell function, and so it actually benefits both therapies. So would it be like crazy to use a CD20 bispecific and a covalent BTK depending on the mutational status?
Yeah, I mean, I may quickly answer. I mean, I think so. I think that's and that's one of the questions was in the question chat as well. So I think, what is the data with covalent after non-covalent BTK inhibitor? I think it's something we'll have to know more. I guess maybe some real-world data. Maybe Lilly folks have some data maybe. So I think that's an important question. I think it's an unanswered clinical question at this time. But certainly, I think combining it with I've been thinking about it. BTK with CD20 and BTK with CAR T, I think is a very, very, very reasonable approach. For that patient who was an older patient, maybe difficult, but certainly in a younger situation, I think that will be a very appropriate approach to consider.
Yeah, agreed. And I mean, obviously not this particular patient, but there is, on the GenMab study, there is some combinations with Pirto and and the antibody, so the bispecific. So I think absolutely, I think combinations are going to be important for the bispecific. I think it will mitigate for the CRS and also enhance response. So I do think you'll see more of that for sure for combinations.
All right. Any other questions from the group? And maybe I will ask 1 question here. I guess someone asked about, could you consider Acala or Zanu in a flare-style regimen, like MRD-guided, long-term? I guess we don't have a trial data, but Will that be considered something to, I guess, think about or maybe consider for your patients?
Yeah. Yeah, I mean, I think you can. I don't think that is unique to ibrutinib and venetoclax. I think we have seen from other earlier phase data that we can deepen these responses as you do extend therapy on, and we see it continue to improve. The issue that I have with kind of a regimen like that is that if you're doing this to try to get to MRD, you can be doing it for a long time and still not necessarily get there. So I kind of look at it as, why do that? Why not just bring in the antibody earlier and just get you there much sooner? And yes, there's some toxicity. You can't ignore that. But if you select the right patient, you can do it safely. You can do it effectively. And I try to stay away from this just prolonged doublet exposure just to try to get MRD, because I still can't guarantee you they can get there. And when you do bring in the antibody, we're seeing the MRD rates of like 90+%. So I can almost guarantee I can get them there and much faster.
All right, we'll take one very quick question. Nicole, if you want to answer. I guess one question is that I think, John, you showed about 314 preliminary data, I guess, head-to-head with ibrutinib, with pirto, and I guess maybe eventually pirto, continuous pirto will come in the frontline setting. Someone asked about that. Is that something, what will be the...
Maybe you should answer, no?
No, I mean, I think we are using obviously a time-limited approach. I think it's the question is the continuous pirto approach, and maybe the question which was asked about...
Is continuous one.
Yeah.
Yeah, so I mean, I think obviously John had mentioned how pirto's is a very clean profile, and there are no doubt there are studies in the frontline setting of pirtobrutinib in combinations, and Nitin obviously has led some of these studies. There are several studies looking at pirto in combination, whether as continuous or time limited. And I think, yes, the question is then, could the non-covalence become first and vice versa? And so I think that that's an open question, and hopefully we'll get that through some of these clinical trials for sure.
Yeah. All right, guys, we're right on time. So thanks a lot for staying back this late. All of you have a good evening, and hopefully see you tomorrow at the Soho.
Yeah.
Thank you.
Thank you.
Oh, you love her.